Hi, I'm Dr. Kiwafe, working at the Center for Research on Filariasis and other tropical diseases, and I'm presenting here the summary of our project entitled Perceived Barriers and Opportunities to Offering Ivermectin Continuously in the Primary Healthcare System. And this was an exploratory study of stakeholders in 5 regions here in Cameroon. So we will just follow this outline to present this project. As background, we can say that onchocerciasis is the second most important infectious cause of blindness, with 25 million people infected worldwide. And despite the strategy proposed by WHO, it is the community-directed treatment with ivermectin, the disease remains prevalent in some areas, as here in Cameroon, where we have about 60% of districts where the disease is endemic, with the prevalence going above 60% in some areas. And the absences during mass drug administration campaign, and also CDDs failing to deliver treatment in household, represent major factors of non-compliance, which promote the disease in communities. So this study was conducted in Cameroon, which is located in Central Africa, with 4 main cultural areas. And this is important because those cultural areas may have different approaches and different habits concerning the treatment and the possibility to adhere to this new approach we are suggesting. So this study aimed to assess the challenges that may be encountered if we want now to be continuously giving ivermectin to local health facilities after mass drug administration. And we also aim to assess the opportunities that may serve as leverage for such an integration. Our primary question was to know what are the challenges and opportunities of partial integration of ivermectin mass drug administration into primary healthcare system. And secondly, which was like a secondary question, we aim to know the cost effectiveness of the actual ivermectin mass drug administration. We therefore conducted a qualitative and quantitative study design from March to September of this year 2022, with the qualitative component consisting of collecting data, in-depth interview, and focus group discussion. From central level to communities, we selected key stakeholders there. And the quantitative component was mostly a cost evaluation of the actual or the last 2021 campaigns from district reports. We used the consolidated framework for implementation research to design our data collection tools and to analyze the data. And qualitative data were analyzed through content analysis using LATI, while we use simple summary statistics for the quantitative part. At the end of this study, we were able to include 259 participants with 98 in-depth interview and 24 public discussion. And as it is presented on this table, we have the number of people who were interviewed at each level of the Cameroonian health system. As opportunities, the main we found were, first of all, the good knowledge about CDTI and onchocerciasis. Also, many people were willing to take the drug, and this was like something good, which means the strategy can be adopted. And finally, the integration of ivermectin distribution into primary healthcare system was considered as a sustainable and simple approach. However, challenges that were identified were the management of adverse events which may occur after the treatment, the risk of misusing ivermectin for other purposes than treatment, and the lack of motivation of CDDs for the drug sharing. And concerning the quantitative part, the administrative drug coverage was 81.5%, with a cost per person treated around 53 CFA francs. Containing promising practice that were identified in this study, the first one is that policymakers and other stakeholders should now consider keeping ivermectin available in health facilities for about 3 months after the campaign in order to supply those who missed the mass drug administration. Secondly, they should consider providing incentive for CDD's motivation and to cover their transport fees during campaign. And lastly, there should be sensitizing population through CDDs, but also through community radios on low rate of adverse events and giving well in advance accurate information about ivermectin mass drug administration. Some lessons that we learned from this study are: during campaigns, some community members refuse to take the drugs because they have personal conflicts with CDDs. Some CDDs also are unavailable or unable to cover their area of distribution of ivermectin due to the very large geographic area, their tiredness, and the lack of reimbursement transport fees that they have to spend for it, which hamper the progression and the success of the actual CDDI. And finally, some people are not aware of the upcoming campaigns, so they may travel during the period, increasing thus the number of people who were not treated during the campaigns. The implication from this study is that our data show promise and potential in integration of ivermectin into primary care system, especially for sustainability of higher coverage levels of ivermectin along the population, leading to elimination, which is the actual goal of the National Onchocerciasis Control Program here in Cameroon. So after this study, the next steps will be to conduct a trial assessing the real impact of that partial integration on drug coverage and even the cost effectiveness of the campaigns and that integration. Finally, this study at the community and health system level has uncovered key components of the current campaigns that need to be strengthened immediately. Among these components, we have the need for more sensitization on low rates of adverse events related to ivermectin in these recent years, as well as the sensibilization to the community. So the key messages are: partial integration is perceived as a simple approach. Adding ivermectin represents an opportunity to sustain the campaign. And finally, my motivation of CDDs and management of adverse events are the key challenges that must be addressed while doing this integration. Thank you for your attention.